Hello, good morning, everybody. Welcome. We're so glad you all could join us. Hi, everybody. If you could take a quick second and say hi in the chat, who you are and what site you're from. We'd love to say hi. Hi, Christine. Good morning. Thank you for being here. Hi, Craig. Thanks for joining us from Sutter Davis. Hi, Elizabeth. Christine, Buke County, Behavioral Health. Great. Thanks for being here. Hi, Lisa, Santa Clara Valley Medical. Oh, Kim, all the way from Illinois. Fantastic. Thanks for joining us today. Terry, Kaiser Woodland Hills. Fantastic. Great. Melissa from Louisiana. Fantastic. Got a good group of folks here. Wonderful. Thank you, everybody. Wow, this is just fantastic. Wonderful group of people. So we'll get started in just a minute, just to give a chance for other folks to join us. Thank you. Good morning, everybody. All right. Well, thank you, everyone. Thank you for joining us for today's webinar. My name is Amy Lundstone. I'm a project manager here with the California Bridge Program. Today, we are presenting the second of a four-part Innovations in Nursing series. This one is Best Practices in Nursing Management of Opioid Use Disorder and Acute Withdrawal. This is great content. This is really the key information that so many nurses need to know and want to know when they're getting started with this program. Just a little bit of housekeeping before we get started. If you have any questions, please put them in the chat. We'll try to work them in if we have time during the session. If not, we have time at the end for a Q&A. We also have closed captioning available. So that option will be showing up on your panelists, or excuse me, your toolbar screen at the bottom for those of you that are interested. And it's a really neat feature. Glad to be able to offer it. This session is being recorded and will be available to you in a couple days. CEUs are available for those who are interested following the completion of a post-event survey, which we will have available both in the chat at the end of the event and in a post-event email. Yeah. So thank you all for joining. If you want to go ahead and get started. So exciting news that many of you probably have already heard of, but those of you who haven't, there have been changes to the practice guidelines for the X waiver. So this means that there is no longer a mandatory education requirement for doctors, PAs, and nurse practitioners. The education requirement used to be 8 hours for doctors and 24 hours for NPs and PAs, which was a barrier. So we're really excited that that's no longer an issue, and we have some great resources available. So you all are in a position to be able to connect with people in your departments and your units and encourage prescribers to go forth and get their X waiver. It's really straightforward. We have created a little bit of assistance because the website can be a little bit challenging to navigate on SAMHSA's end, but it can be done. And we encourage you all to connect with providers to do so. So yeah, now without any further ado, I want to turn it over to Tana Brooks, and our RN Special Advisor, and John Bresson, our Nurse Practitioner Special Advisor. Take it away.
Thank you so much, Amy. I really appreciate the introduction. I'd like to welcome you all to this session. It is so great to be speaking with you all today. Like Amy said, please place any questions in the chat as we go, and we'll try to get to all of them at the end with our Q&A session. So my name is Tana Brooks. I am a special advisor for the California Bridge Program, and I also am currently practicing as a charge nurse in an emergency department. I am at Marshall Medical in Placerville, if you know where that is. John, do you want to introduce yourself?
Yeah, I'm John Bresson, Nurse Practitioner Special Advisor, and I am excited to do this presentation today. And I currently am working in an emergency department at Mercy Samuel Medical Center in Sacramento County.
Perfect. I want to mention that John and I do not have any disclosures or conflicts of interest with the material in this presentation. And let's go over our course objectives. So identify the subjective and objective signs and symptoms of acute opioid withdrawal. accurately assess the severity of opioid withdrawal, understand how buprenorphine works, including its indication, mechanism of action, typical dosing, potential side effects, start a patient on Bupe with an appropriate nursing management, educate patients on opioid use disorder, treatment options, discharge instructions, and advocate for appropriate evidence-based treatment of opioid use disorder. I am especially excited about the content we are covering today because I really think this is crucial information that every bedside nurse needs to know. Okay, so our goal with the California Bridge program is for all patients to have 24/7 access to high quality treatment of substance use disorders in all of California hospitals by 2025. And as we know with everything that we do in healthcare, it really takes a whole team. So that's why we're talking specifically with nurses today. So what we are going to go over is we're going to talk about the current problem, the gap in access to treatment and our current state. And then John is going to be talking about medication for addiction treatment, opioids, opioid use disorder, how to identify and assess for opioid withdrawal. And then I'll be talking about Bupe and how to start a patient on treatment. And then at the end, we're going to talk through some case studies in order to apply the information that we have talked about. We have a lot of information that we are going to talk about today. So let's jump right in. Okay, so we are all familiar with the opioid epidemic. Here's some information from 2019. 70,000 people have died from a drug overdose in 2019. Over 10 million people have misused prescription opioids in that past year. 1.6 million had an opioid use disorder in that past year, and 745,000 people used heroin in that year. So those are staggering statistics, and I think we're all very familiar with them, but let's talk about what we can do about it. And here are some opportunities that we have to actually engage patients in care. So what we found is that 17% of patients that are discharged from acute care do have a substance use disorder diagnosis. And then for when you're looking at emergency department visits, for every 1,000 people over 15 years old, there are 25 drug-related visits. And lastly, 28% of emergency department patients do screen positive for substance use disorder. So when I look at these numbers, these are all opportunities where patients are interacting with the healthcare system, and we have an opportunity to engage them in care and help prevent those overdose deaths. And let's talk about how effective this treatment is to actually treat opioid use disorder with medication. So comparing it with some other medications that we use, when you look at aspirin administered in patients experiencing a STEMI, it takes treating 42 patients with that to save 1 life. For warfarin in a fib, it takes 25 to prevent 1 stroke. With a defib in cardiac arrest, 2.5 to save a life. And then when you look at Buke for opioid use disorder, it takes 2. We have to give it to 2 patients to retain 1 in treatment. Those are really great numbers. And when I look at someone retaining in treatment, that is patients' lives saved because they are at such a lower risk for overdose if they are in treatment. Okay, so here is the California Bridge impact to date. So far with all of our sites, we have connected for over 48,000 patients with substance use navigators. Over 24,000 have been identified with an opioid use disorder, and then there's over 10,000 encounters where medication was prescribed or administered to a patient, which this is absolutely amazing. Now let's talk a little bit about the California Bridge model of care. So there's 3 main aspects to care that we think are very valuable to help patients engage in treatment and be successful. The first is low barrier treatment. The next is a connection to care and community, and the last is a culture of harm reduction. We're going to be talking about all of these components throughout our series of innovations in nursing. Today, what we are going to focus on is the actual treatment aspect of this. So we really want evidence-based treatment to be accessible to patients in the ED and all other hospital departments. And the goal is for that treatment to be provided rapidly and efficiently in response to our patient needs. So when you think about a patient in maybe a hypertensive crisis that checks into the Of course, we want to provide treatment rapidly and efficiently in response to their needs, right? We don't send them to their primary care or to a clinic or something else. We respond to that right away. And that's the same approach that we take with opioid use disorder. All right, so with that framework, I am going to turn it over to John. John, take it away.
Thanks, Tana. And I think this is an important concept here, is that addiction is not a moral failing. This is a chronic disease that requires medical treatment. And I think that's one thing that we forget often, especially when we see patients coming back to the emergency room over and over again. So I think that's one thing that we need to keep in focus during this whole presentation. So. Okay, so what is MAT? What is it? So medication for addiction treatment. It is evidence-based treatment for substance use disorders with medications to prevent withdrawal, help control cravings, and increase compliance. Yes. So definitely, what are opioids? So let's go ahead and put that in the chat, what your perception or your definition of opioids are. So we'll give everybody a few minutes to respond. Remember that opioids bind to active opioid receptors on cells located in many areas of the brain, spinal cord, and other organs in the body, especially those involved in feelings of pain and pleasure. So when opioids attach to these receptors, they block pain signals sent from the brain to the body and release large amounts of dopamine throughout the body. This release can strongly reinforce the act of taking the drug, making the user want to repeat the experience over and over again. Good. So what do you think opioid use disorder is? So go ahead and put that in the chat. And remember that opioid use disorder is the chronic use of opioids that causes clinically significant distress or impairment and consists of an overwhelming desire to use opioids, increased opioid tolerance, and withdrawal when discontinued. Opioid use disorder includes both dependence and addiction. The pattern is similar to other chronic relapsing conditions in that signs and symptoms can be severe and long-term adherence to treatment is often intermittent. So this is just kind of an FYI. So now psychiatry has identified a DSM-5 diagnostic criteria for opioid use disorder. So we're not going to spend a huge amount of time, but at least two of the below criteria are essential for a clinical diagnosis. And this is one of the data points I found really interesting, is that about 80% of people who use heroin first misused opioid prescriptions. 80% I thought was staggering. So as a provider, it's like prescribing opioids for pain, acute pain, you know, I'm part of the problem. So it's really interesting that, you know, we got the start from that. So in the US, about 67,000 drug overdose deaths were reported in 2018. Nearly 70% were caused by opioids. So huge problem, which we can make a significant impact on what we're doing. So what is opioid withdrawal? So what symptoms do you associate with opioid withdrawal? There's a litany of symptoms. So what's interesting is there's subjective and objective data. So when a patient comes in, say that, wow, they have the worst flu ever, feel like they're kicking, you know, they're dope sick, they're very restless, and they can be very agitated. They could be nasally congested, they could have a runny nose, they just feel terrible. And so when we look at them, we see that they're restless or agitated, they're tachycardic, they're diaphoretic, they have dilated pupils, they have rhinorrhea, vomiting and diarrhea, and yawning. And they have this goose flesh that we call piloerection. So the onset and duration of acute withdrawal. Onset can happen up to about 12 hours after using a short-acting opioid. Some patients actually experience it in less than that time, and can experience it as early as about 8 hours. More than 24 hours for long-acting opioid, and more than 48 hours can be up to 72 hours for methadone. And the duration can be 7 to 10 days. And so I don't know if everybody's heard about a COWS score, but this is a clinical tool that we can use to, assess somebody's symptoms. But again, if you look at the slide, the left side of the slide is the patient's subjective complaints. And you can see how it directly mirrors the clinical assessment with a COWS tool. So very, very similar. Turn this over to Tana.
Thank you, John. I appreciate that. All right, so now we are going to jump into how do we actually treat withdrawal. So we've kind of talked about the assessment of it, how to identify it, how to look at the severity of it, and now we're going to talk about how we treat it. And the short answer is with buprenorphine. We like to call it Buke, so you'll probably hear me call it that most of the time today. But we are going to focus mainly on Bupe today because of its safety profile and because of how effective it is. But I do want to mention that there are other medications that do treat opioid use disorder, such as methadone or naltrexone. And we can get you more information about those if you would like, but we're going to focus on Bupe today. All right, so all about Bupe. So this is a long-acting partial opioid agonist. It is primarily used to treat withdrawal and opioid use disorder, but it can also be used to effectively manage pain. And we've seen that it has been shown to decrease illicit opioid use and increase engagement in treatment. So that's why we're really talking about it today, is because of how well it works. And because it is a partial agonist, it treats cravings as well as the physical withdrawal symptoms. But it's also very unlikely to cause life-threatening respiratory depression, and it doesn't create euphoria and helps to prevent overdose. So it actually has a protective effect, which is really cool, because if a patient is on Bupe and then they go and use a full agonist, because of the really high affinity that Bupe has for the mu receptor, they don't experience an overdose, because the Bupe is bound so tightly to those receptors, they don't experience those same symptoms. So it's very cool in that way. All right, let's talk a little bit more about the ceiling effect that we see with Bupe. So Sharon Walsh did a study where she administered a variety of doses to a group of people, including a placebo, and then she asked them at different time intervals, how much do you feel the drug? So, and what you can see on this graph is that how much they feel the drug kind of levels out. So you can see that the 8, 16, and 32 milligram doses are all, the patient's reporting the same feeling for all of those doses. And that's a huge range in doses. So you can definitely see that ceiling effect on the graph there. And then we're also seeing the same pattern with respiratory depression. So I know that's one of nursing's fears, is sometimes we want to really watch very carefully with our opioids that the patient is not experiencing any respiratory depression or overdose signs. And with Bupe, even at high doses, we really don't see the respiratory rate drop below a safe level. Okay, so let's talk about how this works. So when a patient first uses an opioid, they might experience that high or euphoric feeling, and then they would return to feeling normal. And then with each subsequent use, it would be somewhat of a similar pattern. And then at some point, they develop a tolerance and a physical dependence to the drug, to where they are actually experiencing withdrawal symptoms in between uses. And so what our goal is with opioid agonist therapy is to help them feel normal again without experiencing all of those withdrawal symptoms. Now you might be asking, why should we start this in the emergency department, or why should we start it in the hospital? Shouldn't we send them to a clinic? Well, I would beg to differ. I think it's a great place to start it. For one, this is where our patients show up, right? They are at their wit's end. They don't know what else to do. And so they show up in the emergency department in withdrawal asking for help. And this is a great place to start them. It's also a frequent site of care for patients with opioid use disorder. They might not otherwise be engaged in care anywhere else. And this is the one place that they do interact with the healthcare system. And then also we are open 24/7 in the ED, right? So it's a great way to provide care when the patient needs it. So whatever time of day they are experiencing withdrawal, they can come and get help. And then lastly, if a patient is started on Buke and gets a referral to outpatient treatment, it actually doubles the likelihood that that patient will be in treatment 1 month after discharge. So that's really awesome. Okay, let's look at the hospital quick start. This is the treatment algorithm that is put out by the Bridge program to assist providers in starting patients on Buke. And I wanted to make you familiar with it so that you can anticipate what type of management might be ordered for your patient. So the very most important step is verifying that that your patient is actually in withdrawal. So are they experiencing those withdrawal symptoms that we discussed? If not, and they do want to start on Buke, we just need to wait until they start experiencing withdrawal. Because Buke has that really high affinity for the mu receptor, if we administer Buke before the patient is in withdrawal, it acts somewhat like naloxone in that it can precipitate a withdrawal. So we really want to make sure that they're actually in withdrawal prior to starting the medication. So we verify they are in withdrawal, and then we go ahead and administer a first dose of Buke. Very important to have the patient dissolve it in their mouth and not swallow it. If they swallow the medication, they won't get as much of the drug, so they might not get a high enough dose for it to be effective. Okay, so after they get that first dose, we wait about an hour and then we reassess and see if symptoms have improved. That first dose is a really good differentiator. It gives us a moment to pause and consider the differential diagnosis. So is there something else we're missing besides the withdrawal? Some other things that might mimic withdrawal are DKA, sepsis, flu, things like that. So that's definitely something to be aware of as you're managing this patient, is if they are not getting better or they're getting worse, we need to stop and think about what other things could be causing this. So as long as everything is going okay, we go ahead and administer a second dose of Buke. And then the maintenance treatment that you could anticipate is somewhere around 16 to 32 milligrams a day. It kind of depends on the patient's use, the severity of withdrawal, and their specific circumstance. So you might see doses outside of this range depending on the situation. So it's not a cut and dry, absolutely have to be within 16 to 32, but it's just a general range that you can anticipate. Okay, so we are going to talk about the different formulations of Buke. So what other names have you heard of for buprenorphine? Put it in the chat while I'm talking through this. Tell me about all the different names that you've heard of it. All those different brand names. Okay, so first one we're going to talk about is the buccal strip or sublingual tablet. This can be formulated as a monoproduct or in combination with naloxone. And one of the common misconceptions that I've heard is that it's believed that the naloxone component actually helps to prevent respiratory depression, but that is definitely not true. So I just want to reiterate that that is not the function of the naloxone component. The naloxone component actually functions as a deterrent. It is inert when the tablet is taken sublingually, but it becomes active if the tablet is snorted or injected. So that would be the benefit to providing the combo product. The tabs or strips are often used for induction of treatment during acute withdrawal, and then they can also be used for maintenance therapy. Typical dosing range is anywhere from 2 to 32 milligrams. It kind of depends on the situation again. And then you'll see a frequency of dosing as daily, BID, TID, or QID. depending on the patient's needs. Some patients, especially those with chronic pain, seem to benefit from splitting the total dose up throughout the day to provide better pain management coverage as well. But other patients do just fine with daily dosing. So it kind of depends. The onset of the sublingual formulations is about 5 up to 20 minutes and peaks at about an hour. Okay, the next one, the extended release subQ injection. Does anyone know what the brand name is for that? This is commonly used for long-term chronic treatment of opioid use disorder, often for patients already stabilized on the strips or tabs, but not exclusively. It can be desirable for patients due to the convenience of it, and it can also help those patients who struggle with daily dosing. So this injection is given once a month. Oh, Tammy, great job, thank you. Yep, Sublocade. It comes in a dose of 100 or 300 milligrams. All right, the next formulation is the Transdermal Patch. This is often used for pain management, and it can also be used for transitioning patients from methadone to Bupe. It comes in a variety of doses, and the patch is changed every 7 days. And lastly, we have our IV and IM solution. This is very helpful in cases of severe emesis. If the patient just cannot tolerate the tablet or the strips, this could be utilized. And then it's also really helpful in the perioperative care environment. It comes in 0.3 to 0.6 milligram doses and is often given every 6 to 8 hours as needed. Has a very rapid onset and peaks at about 5 to 10 minutes. Perfect, and Butrans, yes, that's the name for the patch. Thank you so much. Okay, so you might be asking, what are some treatment tips? And honestly, the most important thing, like we talked about earlier, really is to just treat this like any other chronic condition. And so some of the ways we treat chronic conditions are we provide care promptly when the patient is seeking care. When I think about treating a DKA patient, when they arrive in the emergency department in crisis, that's when we treat them, right? Also, low barrier care. We want to minimize requirements prior to receiving treatment. So we would not necessarily recommend a toxicology or drug screen prior to receiving a medication. Sometimes we use those tests to inform care when appropriate, but we don't want to create all of these barriers for patients so that they are, feel like it's really hard to access the treatment. And then also something that's very, very important is that it's okay to treat even if a patient has not continued treatment in the past. So when I think about that DKA patient, again, maybe they didn't continue treatment in the past, but they're here asking for help. Of course, we're going to treat them. And the same is true for opioid use disorder. We want to, if they show up in the ER or they're in the inpatient unit in crisis, going through withdrawal, we want to treat them if they are interested. They really are safer while they are on Buke for however long that is. I would like to pause briefly for any questions before we jump into the case studies. Let's see. We usually wait up to an hour after the first 8. An ER hour, I love that, and involve the patient in the decision to give another 8 or up to 24 to a total of 32. If the patient has previously been maintained on 32, this may be the dose they get. Yep, perfect. I love that you're pointing out involving the patient in the decision. I think that's very important and valuable. Initial dose recommended to be 8. Are there any weight-based recommended starting dose? John, do you have any thoughts on that?
No, there are no weight-based starting doses. It's just a standard dose.
Perfect. What about ETOH? Is it good to check level if ETOH is suspected? It's really not contraindicated to treat a patient with Bupe even if they are using or drinking alcohol. So maybe if the alcohol level would inform care in another manner, that might be appropriate, but I don't think that you would need to get the level prior to starting Bupe. What do you think, John?
Absolutely not, because you're going to involve the patient on the subjective data. Again, how do they feel? When was their last dose of injected heroin or pills or whatever happens to be their opioid of choice? So definitely the patients will exhibit signs of acute opioid withdrawal.
Perfect.
Tana, there was a question about monitoring after the dose. Can you speak to that a little bit?
Sure. Yes. So the main point of monitoring after the first dose is to see if, make sure that we don't cause a precipitated withdrawal, and also monitor and make sure that their symptoms are improving and this was the right direction to go with their care. There aren't any cardiac monitoring or pulse ox requirements for Buke because of that ceiling effect we talked about. It's a very low risk medication and very safe. So there's not any specific nursing monitoring as far as vital signs, but really we just want to make sure that their symptoms are improving and set up any follow-up arrangements. Okay, does the RN or provider complete the COWS and how often? Great question. So different facilities may require nursing or medicine to complete a COWS score. From the Bridge program side, we do not require or necessarily recommend the COWS at a specific time interval. It can be very helpful for newer clinicians to utilize the COWS in order to kind of get a feel for how severe the withdrawal is. But it's not necessary to complete a score prior to a dose and at a certain time interval. So it would really just be based on if your facility has a certain policy for when they require it. But really you want to, the main point is to trust the patient self-report. Patients don't come in pretending to have an opioid use disorder just to get Buke. So really trust their report and assess the severity based on your nursing judgment. So whether that's utilizing the COWS or just writing a note about what their symptoms are, that would be up to your facility and your nursing discretion. Does that answer your question, Kelly? Perfect.
And
Okay,
one point, Dana, is remember to evaluate the patient's pupils. I mean, that's part of the assessment, but that gives you a lot of information. Is this truly opioid withdrawal?
Great, thank you. Yeah. Okay, so John and I are going to jump into the case studies. These are some common situations that we have actually both faced in our own practice, and we would like to discuss them in order to hopefully provide some helpful insight. Okay, so first case study. When discussing treatment options for opioid use disorder, the patient says, I saw your sign in the lobby about getting off pain pills. I tried Buke before and it really didn't work for me. How would you handle that, John?
Well, first off, I actually wonder what the patient's initial dose was. Was it high enough based on the patient's symptoms? So definitely I would ask what their baseline dose was and would most likely end up increasing their dose so that the patient didn't have any withdrawal symptoms, so that they felt much better.
Yeah, that's what I was thinking too. I was also thinking maybe they swallowed some of the dose and it made them feel bad.
And they can certainly do that. I mean, that's one of the things that some patients do have, is that they swallow it instead of letting it dissolve in their mouth.
Yeah. I appreciate that this patient pointed out that they saw the sign. I know that in my ER, it's actually helped some patients engage in care because they actually saw the sign and they were like, oh, I didn't know you actually had this treatment available or something of that sort.
Yeah, that happens in our ER too. We have a huge sign out in front that says that we do treat opioid use disorder.
Yeah.
Exactly the same sign that we have out there. So.
Yeah, awesome. Thanks, Amy. How many of you have signs posted in your hospital? Yes, that's this slide right here is exactly what it looks like. You were probably typing that right before I switched. Not yet. Well, we have some templates on our website if you would like to print those off and post signs. We have templates made for you. Awesome. Okay, case study 2.
So a patient has been admitted to the med-surg unit for an abscess and associated cellulitis that requires IV antibiotics. About 10 hours after admission, the patient becomes irritable, restless, and appears diaphoretic. He is also reporting nausea. He reports he needs to go outside for a smoke. What do you think these symptoms can indicate in this patient, and what treatment would be the best interest of this patient if he is interested?
I love this. Yeah, thank you, John. I appreciate this case study, because I know when I was a floor nurse, I saw this happen and I didn't really know what to do about it. So it's really awesome that we have options for treatment now. So I mean, what that looks like is that he's probably experiencing withdrawal. He was probably using some type of opioid, and now that he's on the, an inpatient, if he didn't feel comfortable reporting what he was taking because it wasn't prescribed, he didn't get something ordered on the inpatient side, and now he's experiencing withdrawal. So I would identify those symptoms and hopefully have a conversation with the patient and see if he was interested in getting on treatment. And then I would advocate for him to receive Buke, get started on Buke while he's an inpatient, and then hopefully he could follow up when he's discharged.
Excellent. And remember that these patients can be anywhere in the hospital, not just in the emergency department.
Right. Okay, next one. At a nursing conference, an ED nurse says, when we start patients on Buke, we always place them on a cardiac monitor. We watch them for at least 4 hours after starting. Ideally, we send them over to the clinic rather than holding up the ED with these patients. I really don't think the ED is the right setting to start patients on this. What do you think?
I 100% disagree. The ER is an incredibly perfect place to start these patients. These patients do not need to be monitored long. I think the longest part is getting the medicine from the pharmacy. While the patient is sitting in the chair, we actually initiate patients while they sit in the chair in the hallway, and then monitor them within an hour. If their symptoms are not improved, we give them a second dose. By that time, if they're feeling better, we can discharge them with a prescription. But these patients do not need to be on a cardiac monitor. We put them in the hallway and we discharge them from there. So definitely a very quick and very effective way of treating opioid use disorder.
Yep, that's exactly how we do it in my ED as well. They're often seen in the fast track area. Okay. Next one.
So a patient tells the nurse, I think that medication you gave me is making me nauseous. When do you think I can get off of Buke?
Yeah, this is a very common thing for patients to say. For one, to address the nausea, we touched on this earlier, but really it's maybe the patient is swallowing it. Sometimes that can make them nauseous, or sometimes they just have an incompletely treated withdrawal, so they don't have a high enough dose to adequately treat their withdrawal. So that might be something to address. And then also when patients are asking when they can get off of Buke, I think that it's important to set care expectations with the patient. This is a chronic disease and we expect chronic treatment. Now, is that to say that they will never get off of it? No, some patients might, but that's not necessarily the primary goal. And I think setting good expectations as well as shared decision-making with the patient is very important. So what is the patient's goal? So actually that leads right into the next slide really well there. So, what does success look like? What are the patient's goals? Is it to be able to take their kid to school every day? Is it to hold down a full-time job and not, maybe they are struggling with getting to the methadone clinic every day and they want something that allows them more freedom. So what are their goals and how can we meet them is more of the where we want to keep our focus rather than just like, I want to get off this medication as soon as possible. Do you have anything to add on that, John?
No, that's perfect. And it's always involving the patient in this. The patient is actually going to be an ally in this. We need to involve them at every step, including, as far as follow-up with treatment and how long the treatment is going to be. I mean, they really want to get on with their lives.
Yeah. All right, let's review some of the key aspects of discharge planning. These are very straightforward nursing 101 pieces of information, but I just want to review it because it's very important for these patients. So updating contact information in the record, this allows the team to follow up effectively as long as there's, good up-to-date information, making sure the patient actually got their prescriptions that they need, confirm any follow-up appointments as needed, provide them with the substance use navigator contact information. I think that this is very valuable for patients so that they have someone they can call if they're having trouble, if they can't get their medication or they can't make it to an appointment, giving them access to someone to contact to get help. Determining they have a safe ride home, and then also dispensing naloxone. I know my emergency department has a naloxone distribution program, and some of you may or may not have one. We'll be talking about that more in the next session, but it's a really awesome thing that we can provide to patients to provide that extra safety net and extra security. I know that I've actually spoken with patients who have used this and saved other people's lives, which is amazing. It's really, really cool to be able to provide that to patients. If you don't have a program where you can hand it to the patient, make sure that they get a prescription for it. And then also reviewing discharge instructions, including the suicide hotline, all those things. And then I think something that we sometimes forget to talk about is safe storage of medication. So storing it in a safe, secure place, out of the reach of children, and out of reach of anyone who might get into it. So that's very important. Let's move on to the next thing. So as we wrap this up, I want you to put in the chat one take home from today. What one specific action can you take to utilize best practice nursing interventions for opioid use disorder? So think about it and put it in the chat. Maybe you'll go and teach a coworker about how Buke works. Maybe you'll talk about its safety profile or the ceiling effect. Maybe next time you see a patient who's in withdrawal, you'll recognize the symptoms and advocate for them to receive Buke. Maybe you're a hospital administrator and you'll show this video to your nursing staff so that they have best practice recommendations for treatment. All right, Lisa says work on naloxone distribution, awesome. Christine says recommend starting Bupe sooner rather than later, awesome. Make sure our patients are aware of this service, that is so important. Trust the patient self-report, yep. I have yet to see someone say that they're in withdrawal just to get Bupe and they didn't need it. Never seen it. All right. Use info for our staff ED, awesome. Working on creating education for our ED department. This helped clarify materials, awesome, great. Doing a lecture tomorrow for new RNs. We'll share some of this info. Awesome, I'm so excited for you. That's great. Let us know if we can help you in any way. Okay, we are going to move into the Q&A session. So any other questions that have come up? I think I saw a few come through earlier. Let me find them.
Yeah, Tana, I have them pulled aside.
Oh, perfect.
Yeah, so there was a question from Kelsey earlier wondering if there's a best screening tool for inpatient assessment. And so I'm wondering, maybe Kelsey, you can pop into the chat if we clarifying assessing for opioid use disorder. I know that was during one of the case studies. As a whole, Tana, you can speak to sort of screening and cows. I know you touched on that earlier.
Yeah, that's a good question. I don't think that I am not aware of an official screening tool. I know that there are some tools that hospitals have created to screen for opioid use disorder, such as is the patient prescribed a narcotic? Are they specifically asking for a narcotic? Do they check in with certain complaints? There's some screening tools, but I don't think there's any standardized tool that there is that would screen for on an inpatient assessment. John, are you aware of anything?
No, I'm not. And again, it's based on the patient's symptoms. I mean, you can certainly use a COW score, but again, it's your clinical assessment of the patient and your expertise at the bedside to alert the providers that, hey, could this be an opioid withdrawal? So we need to treat that with Buke.
Mm-hmm.
Great, thank you. Tracy had a question earlier about how long it would take for treatment to start eliminating symptoms or managing symptoms, maybe both sort of short-term and long-term.
Yeah, do you want to answer that, John?
Immediately. basically, once you initiate them in the ER, their symptoms have abated by the time that they're discharged. You're discharging them on the same dose that you initiated them on, and you're writing them a prescription. And I tend to write, especially now in the pandemic, I write them a month's supply of buprenorphine so that they can go ahead and manage their treatment, get in touch with our substance use navigators early on. So definitely, by the time they leave the ER, they are feeling much better.
Yep, it's amazing. I have taken care of patients that are, curled up in a ball on the bed, absolutely miserable. And within, I don't know, 30 minutes, an hour, they are acting like they are a normal person again, and they feel good, and they're just so grateful, and they walk out of the department and say thank you, and it's just amazing. It's night and day.
Yeah, agreed.
Okay, I know someone asked a question about length of stay. So I wanted to get back to that. Length of stay in the emergency department is pretty quick. We see them in our fast track area, I would say within 2 hours, they're in and out.
Yep, 100% agree.
I think that question also was in regards to the scenario with a patient with an abscess, where imagine the length of stay would be more related to how the abscess was being resolved in the IV antibiotics versus opioid use disorder treatment. Is that accurate? Tana,
Yes.
John? Yeah.
Yes, actually, that
Yeah.
definitely,
Oh, sorry.
because again, they're going to need IV antibiotics because where they septic coming in. So definitely will need IV antibiotics. But again, it's like recognizing withdrawal symptoms early on and treating them with Buke is key. That's the key component of this. Why do they have the abscess? Are they skin popping, heroin? What are they doing?
Mm-hmm. Someone else asked about managing precipitated withdrawal after initiating Buke. So if that does happen to happen, then the recommendation is supportive treatment and more Buke. Honestly, because they're now in a severe withdrawal, sometimes they might require very, very high doses of Buke, and there is a resource for providers. There's a warm line that they can call and get help with managing treatment if they need it. But what I have seen in my department is that more higher doses of Buke does help to manage that precipitated withdrawal. John, do you have anything to add on that?
No, absolutely. Just increase the buprenorphine.
Mm-hmm.
Again, you're going to reach the ceiling effect eventually.
Yes.
There was a question from Tracy about, have you encountered any issues with psych patients for patients concurrently taking buprenorphine and various psych medications?
I have not seen that. I don't know if you have as well, Tana, but again, most of our psych patients, I wouldn't say in general terms, but some psych patients do have concomitant substance use disorders. So a lot of their medicines are attached to different receptors, because remember, opioids attach to the mu receptor. So we're trying to block that with the buprenorphine. So it generally shouldn't have a side effect profile based on what medicines they're taking.
That's what I've seen as well. Yeah.
There was a question from Sue earlier, wondering about what if a person works somewhere that drug tests? How would you explore that with them?
That's a good point.
That is a
But
great
again,
question.
with any treatment, for chronic disease, some medicines are going to pop up, positive for amphetamines, positive for benzos. Those are types of things, and you just have to disclose that you are on buprenorphine. And I'm not sure if buprenorphine does show up on our urine toxicology. That's not something I think that's on the panel that we use at Mercy San Juan.
Yeah, I don't know if Ariana's on the call, if she knows for sure. I don't know if I could confirm that. But I do know that, if the patient does already have an opioid use disorder, they're probably already positive for opioids on their drug screen. So I think that helping them get in treatment so that they can function better and transition to, in a more positive direction if they want to, is probably still a good idea. And maybe that's someone that wants to do some more drastic measures and lifestyle changes and wants to try to get off Bupe at some point in order to manage that, depending on what their profession is. But that definitely would be a shared decision with that patient.
Absolutely.
And Reb, one of our
thank you,
docs
Reb.
and regional directors popped in. She said it depends on the drug screen. So exactly, some have it and some do not.
Thank you. Perfect. All right, I did want to make a comment. Someone had mentioned that they start a lower dose with their adolescent patients and not jumping too far into adolescent treatment. I think it's important to remember to make sure that we're adequately treating the withdrawal. So lower doses sometimes have the risk of inadequately treated withdrawal. So just something to be thinking about.
Yeah, and that was what point in one of our scenarios is that, underdosing is key. And remember that you're going to assess these patients, their subjective information is going to be crucial. How do you feel? And they're going to tell you right off the bat how they feel.
Yep, agreed.
And we anticipate having more resources for youth in the near future. It is definitely an ask that we are aware of, and we are collaborating with others to determine how best to support the youth population, because they are an identified population. If we can help folks get support early on, then we can make a larger difference in their life later on.
Yeah, I appreciate it being brought up. I'm glad you're thinking about it, and more to come on that. Any other questions before we wrap up?
Now's your time, folks. You got
two
two subject matter experts here. No question too small or too silly. Thank you, Kimberly. Glad you could be here as well. Right, well.
Fentanyl related withdrawal, any thoughts? Ooh, have you seen that, John?
I have not. But again, now that it's brought up,
yeah,
I will most likely see it.
Reb or Ariana, do you have any thoughts on that? I don't feel like I'm an expert on carfentanil, so if anyone wants to jump in on that.
Ariana or Reb, if you want to mute instead of type, or unmute instead of type, please feel free to do so if you're able to answer that question.
Yeah, I mean, we haven't yet confirmed it in our area, but that's just honestly a lack of testing ability. It should just look like all the rest of our fentanyl and our highly potent opioids. So I wouldn't consider it or treat it any differently, and also being aware that we will very, very, very unlikely be able to diagnose it anyway until it starts showing up in our coroner's reports, which should be unfortunately pretty quick when it enters the community.
Thank you, Reb.
Yep.
All right, so Margaret asked, how do you address the stigma of substance use disorder at your facility? I'm glad you asked that question. That is a huge piece of this. And I think finding those frontline champions that you can in your units and educating them on how we can approach these patients with respect and with the care that they need. Treating it like a chronic disease really helps with stigma, because we do have treatment options. I know one of the things that helped me the most was just, instead of not having anything to do for these patients, it was really hard when, someone checks in and it's like, well, yeah, you're suffering, but there's not a lot I can do for you. But having an option to treat this has really helped a lot, because it's like, oh, okay, you checked in, you use heroin, you're in withdrawal, you want to get off of it. Okay, let's get you started on Buke. Like, it's a lot easier to approach that from a very practical standpoint and move forward in a positive manner, rather than just being like, oh, they're here again. What am I supposed to do? What do you think, John?
Yeah, I 100% agree. Now that we're kind of experienced more now in treating substance use disorders in the ER. Most of the nurses are aware of it when they come in. The patients are asking for help right off the bat, and it's like, hold on, let me see if the provider who's on, and then we can get you in the back and we can get you started. So it's really been really nice. And I think there's been like this switch because nurses are now looking at it more as a chronic disease and treating it as such. You know, patient needs, you know, glucose or insulin for their hyperglycemia. They need blood pressure medicines for like hypertensive, you know, crisis. So those types of things. And I think that mindset has changed slowly over the course of time that we started this program.
Yeah, agreed. Also, there is a culture of care handout that is a nursing resource that we have created. So that could be a helpful document. It's just, I think it's between 1 and 2 pages long. If you wanted to print it and give it to your nursing staff to provide additional education on that culture of care and not stigmatizing or discriminating against patients, that would be a good resource that you could give to your nursing staff.
Exactly, Tana. And, you know, there's an element of words really matter. So using appropriate language when you're referring to a patient, to their scenario, and having the courage to correct your coworkers or other members on your team if they are using language that could be hurtful in ways. And, you know, you find your own comfortability with having those conversations with your team, but those are important conversations because you get to lead by example and be a member of your team, creating change that drastically improves patient lives.
Yep, I think that's one. I appreciate you bringing that up. I think that's something that's helped a lot as well. Is like, I just model the language that is respectful of those patients and appropriate for those patients. You know, the person first language. You know, person who uses drugs, person with a substance use disorder, rather than calling them a junkie or a druggie or whatever. I just model that language, and it starts to rub off.
Exactly.
Right. OUD versus chronic pain. Our docs tend to move to continue opioids. Should they consider Bupe and discuss with the patient? It kind of depends on the setting that you're in. I don't know if, yes and no. I mean, it kind of depends on the situation. I don't know if you want to answer that, John, but I do think if the patient is not in withdrawal yet in the ED, that's not something you're going to hold them in the ED to start, but you could consider, you know, discussing with the patient if they want to switch. I don't know. That's a good question.
It is a good question. And, you know, some patients do come to the emergency room for chronic pain issues and are requesting narcotics. But we do have, at my facility at least, we do have a chronic pain policy that, you know, our emergency room providers will not be writing any prescriptions for any chronic pain patient because they need to follow up with their pain management specialist so they can determine when and if they can and should be taken off their opioids. And again, if they're going to need any type of treatment at that time. But it's not something that we would do in the emergency department.
Thanks, Debbie. All right.
Great. Thank you, Tana and John, for just a fantastic presentation and such valuable information. And to everybody in the chat for, you know, asking your questions, for being here, for thinking forward about how to support your team and support programs. Our next Innovations in Nursing series is coming up in September. So you have a little bit of time to encourage your team to join. And it's all about harm reduction. It's a perfect match, harm reduction and emergency department nursing. It makes perfect sense. You treat people for opioid use disorder in the ED and you set them up for success by discussing and providing harm reduction resources. So there's a registration link in the chat and then also this QR code if you feel so inclined to scan, that is available as well. And then here's Tana and John's contact information. So we do offer you know, technical assistance support specific for nurses and nurse practitioners, just like we have support for other prescribers. You know, California Bridge recognizes that this really is a team effort and we want to be able to support everybody in what they're doing and help everyone to be successful. And for those of you who are interested, we do have CEUs available for if you can complete the survey. There's a link in the chat and that will also be included in the post-event email. So we'll include in the email that and as well as links to all these. And we have a boot camp for champions session number 7 coming up with Dr. Andrew Herring. And that is going to be on this Thursday, June 18th. So coming up pretty quick here. And this is advanced buprenorphine. So this is more about injectables and slightly more complex scenarios. It should be really fantastic for those of you who are interested and ready for a little bit of a deeper dive. Again, the registration link is in the chat for that one. Thank you. And, you know, we really invite you to join us in this journey, follow us on social, this is an opportunity for you to engage, for you to ask questions, for you to be a part of this in a more involved way. So we've got a lot of different options: Facebook, Twitter, Instagram, YouTube. So pick the one that's right for you and come join us in this movement. Yeah, so thank you again all for joining us today. We'll hang out for a few minutes if there's any additional questions, but really, we really appreciate your time and appreciate all the engagement with us today.
Thanks, Reb.
Thanks, Reb. Great to have you with us. Thanks for chiming in with some of your impressive knowledge. Yes, Terry, we will include the link to complete the survey for the CE use. So that will be included in the email for anyone who attended in real time. For those of you watching on YouTube, unfortunately, that option is not available, but we appreciate you watching this on YouTube. All right. Thanks again, everybody, for joining us. We'll see you at the next one.